So, starting with the new phase of HER2 in breast cancer, we'll be seeing about HER2 new expression, HER2 low expression, and what is HER2 ultra low expression. So, what is this HER2? It basically stands for Human Epidermal Growth Factor Receptor 2, which is also called as ERB2. It's a proto-oncogene which is located on the long arm of chromosome number 17. It encodes a transmembrane tyrosine kinase receptor which belongs to the EGFR family, that is ERB2 family. Now, we should remember here that EGFR family has 4 HER members. We have HER1, HER2, HER3 and HER4. Now, amongst these 4, only HER2 is the one which is not dependent on any ligand for its activation. Vis-a-vis HER1, HER3 and HER4, they have the ligands which are responsible for their activation. So what do we mean by this is this particular protein will have an extracellular domain, a transmembrane domain and an intracellular domain. Ligand will bind on the extracellular domain which will in turn activate the intracellular domain to further activate the signaling pathways. However, HER2 will not act in that way. So how does basically this HER2 act is when the other members of this HER family, that is HER1, HER3 and HER4, they have the ligand attached to their extracellular domain, they will go and bind with that of the HER2. That is, they will pair with this HER2. So this is basically pairing or the dimerization of this HER2, which will in turn lead to the activation of the intracellular domain. Herein we have a tyrosine kinase domain. So activation of this will lead to phosphorylation, that is addition of extra phosphate residues, which will in turn lead to the activation of the further signaling pathways. So this was about how the normal HER2 will act. So because of this, HER2 is involved in the cell growth, survival and differentiation by triggering the 2 major signaling pathways in the cell cycle. That is, we have MAPK pathway which promotes cell proliferation, and then we again have this phosphoinositol kinase pathway which promotes cell survival, and it also acts as anti-apoptotic pathway. Now coming to what exactly goes wrong in cancer and how HER2 is responsible for making the cancer aggressive is, see, in about 15 to 20% of breast cancers, the HER2 gene is going to be amplified, meaning the expression of this protein is going to be more. Now, more expression of the protein means more signaling pathway. More signaling pathway means more cell growth and more aggressive the tumor is going to behave. So, whenever there is an amplification of this gene or there is an overexpression of this protein, it will indirectly make the cancer or the tumor very much aggressive, and it will act as a potent oncogenic driver. So originally, because of this presence or overexpression of this HER2 or no or absence of this HER2 overexpression, the breast cancers have been divided into whether they are HER2 positive or HER2 negative, meaning HER2 positive tumors are those wherein this HER2 gene is amplified or wherein the HER2 protein is overexpressed. So they are going to be very aggressive tumors. They will have a bad prognosis, but because of the expression of this protein, they are also the candidates for targeted anti-HER2 therapy. Okay. Vis-a-vis, the HER2 negative tumors are those tumors which will not show any overexpression, and because they are lacking any expression of this HER2 protein, they are not targeted by this anti-HER2 therapy. Now coming to when do we perform this HER2 testing is whenever there is a primary invasive breast carcinoma. In all such cases, it is mandatory to perform a HER2 testing. And along with that, also the metastatic sites or the recurrent site is also necessary to undergo HER2 testing. So if a patient is having a breast carcinoma and if you have done a biopsy from a metastatic site, it does not mean that the primary site and the metastatic site is going to show similar HER2 expression. So even a metastatic site has to undergo HER2 study to see whether they are expressing HER2 or they are not. Again, what is the specimen which is required, like on what specimen can you perform this HER2 testing, is it could be a cytology specimen, like if you have performed an FNAC or likewise, or if it's a core biopsy specimen, or even the resection specimen can do, right? The necessity is the specimen should be fixed in 10% neutral buffered formalin for at least 6 to 72 hours. Now this fixation is very much important, very much necessary, and the cold ischemia time should be less than 1 hour. So what is basically this cold ischemia time is when the organ has been removed from the body but it has not yet been kept into the fixative or the formalin. So why this is important is whenever the organ has been removed, it is cut off of all the blood supply and the oxygen, and now the tissue is going to undergo degradation. So what does the fixative do is the fixative will arrest all these proteins in the state in whatever they are, right? So if you have not kept that operated organ into a fixative, it means that till the time it is going to undergo degradation, and whenever this protein will undergo degradation, it will lose its antigenicity, which will give us a error in its reporting whenever we perform an IHC on such tissues. Hence, the cold ischemia time documentation is very important, and it is necessary that you perform an IHC whenever the cold ischemia time is less than 1 hour. If it is more, then the results can be erroneous, right? And avoid decalcified tissues, because whenever the tissue has been subjected to the decalcifying agent, it will again lose its antigenicity. Coming to how to perform this testing of HER2, there are two methods. You have an immunohistochemistry method, that is IHC, and a in situ hybridization, that is ISH. Now IHC, that is immunohistochemistry, will check for the expression of this protein, and ISH, that is in situ hybridization, it could be a FISH or a SISH, it will check for the gene amplification. So whenever on a ISH you find that the gene is amplified, you will label them as HER2 positive, and if on a ISH it is not amplified, you will define them as HER2 negative tumors. Coming to IHC scoring, we say that the score on IHC is 3+ whenever there is a complete circumferential membranous staining in more than 10% of the cells, and the intensity of the staining is going to be very strong. In that case, you will label them as HER2 positive tumors straight away. On IHC, if the expression is complete membranous staining in more than 10% cells with the intensity that is ranging between weak to moderate, or if the intensity is strong but the staining is not circumferential but it is incomplete, then the IHC score of 2+ is given. We call them as equivocal tumors, and whenever they are equivocal tumors, they will reflexly have to undergo in situ hybridization to know the exact expression or amplification of this HER2. Then coming to IHC score 1+, whenever there is a faint or incomplete membrane staining in more than 10% cells, you call them as 1+ on IHC, and they are HER2 negative tumors. Again, when there is no staining or faint staining in less than equal to 10% cells, IHC score of 0 is given, and they are again labeled as HER2 negative tumors. One thing to note here is only the membranous staining will count. Please ignore the cytoplasmic staining as well as the in situ component staining. Only count the membranous staining in the invasive tumor cells. Apart from the studied categories, there can be other less common patterns as well, which can be considered as equivocal. Like if you have a circumferential membrane staining which is strong in intensity but seen in less than 10% of the tumor cells, or the IHC staining that is moderate to strong in intensity but incomplete, like it could be basolateral or lateral, which is often seen in micropapillary breast cancer. So they are labeled as equivocal, and they will have to undergo in situ hybridization to know the HER2 status. Again, indeterminate expression can be seen because of improper specimen handling, or because of the crash artifact, or there are edge artifacts and any errors in the analytic testing, or the controls are not proper. So in these cases, the reasoning for an indeterminate result should be reported, and an additional tissue should be acquired for testing of this HER2 expression. Now coming to the ISH reporting, that is in situ hybridization, usually we use a dual probe. Now here, as we can see in first column, you have a HER2 by Sep17 ratio, and in the second column you have a average HER2 copies per cell. So basically in this case, whenever you are performing an IHC, an ISH, it should be performed on the same tissue on which the IHC was performed, and during performing an in situ hybridization, we will be counting at least 20 cells which are non-overlapping and 20 tumor cells. Okay, so whenever it is subjected to the in situ hybridization, you will get red signals and green signals. Red signals or orange signals are for HER2, which will be giving you the information about the presence of HER2 in that particular cell, and Sep17 will will be stained by green color, which is present at the centromere. So basically you are giving out an information that in a particular cell how many HER2 signals are present. Okay, so for example, if we are counting 20 cells, we will count all the red signals in those 20 cells, then we will count all the green signals in those 20 cells, and we will divide the red signals by these green signals. So you get a HER2 by Sep17 ratio, right? Again, all the red signals should be counted, and they should be divided by the number of total cells in which you have counted these red signals. For example, 20. So that will give you an average HER2 copies per cell. So as we can see in this table, whenever the ratio is more than equal to 2, then we see how many average HER2 copies are there per cell. If it is more than equal to 4, you label them into group 1. If it is less than 4, you label them in group 2. Again, if the HER2 Sep17 ratio is less than 2, you see how many the average HER2 copies per cell are present. Whether they are more than equal to 6, placing them in group 3. Whether they are between 4 to 6, placing them in group 4. And whether they are less than 4, placing them in group 5. So remember here, group 1 is when the ratio is more than equal to 2 and the average copies are more than equal to 4. So it signifies that already the HER2 is overexpressed, right? The average number is also more, by ratio also per cell is obviously having more HER2, so this group 1 is going to be positive for HER2 expression, right? Again, coming to group 5, you have HER2 by Sep ratio less than 2, and again average numbers are again less than 4. So this is by definition going to be negative. That is, there is no overexpression of HER2 in this case. So group 1 on ISH is positive, group 5 on ISH is going to be negative. And if in the in situ hybridization method you get your report falling anywhere between 2, 3 and 4, then we will see further how to go about these tumors. So group 1 is going to be negative and group 5 is going to, group 1 is going to be positive and group 5 is going to be negative for HER2 overexpression. So whenever you on ISH have the tumors which are lying in the category of group 2, group 3 and group 4, so in that case ISH alone is not going to be useful. So IHC should also be taken into consideration while reporting these cases. So based on both IHC and ISH, you will say that these tumors are negative if on ISH it's a group 2, but on IHC it's showing a score of 0, 1 plus or 2 plus. If on ISH it's a group 3, on IHC it's showing an expression of 0 or 1 plus, and on ISH it's a group 4, but on IHC it's showing an expression of 0, 1 plus and 2 plus. Again, if these tumors are going to be positive based on both IHC and ISH if it's on ISH showing a group 2, on IHC it's showing a 3 plus expression, on ISH it's a group 3, on IHC it's showing expression of 2 plus or 3 plus, and on ISH it's a group 4 with IHC expression of 3 plus. So likewise we will come to a proper conclusion on whether these HER2 tumors are showing HER2 gene amplification or not in ISH, that is in situ hybridization reporting. To summarize, according to the 2023 ASCO CAP guidelines, which includes both IHC as well as ISH results, HER2 status is defined. In IHC, if it's a 3 plus expression, you say that the tumors are positive for HER2. On IHC, if the expression is 0 or 1 plus, you say that the tumors are negative for HER2. And if on IHC you have a 2+ score that is equivocal, it is further subjected to in situ hybridization, and ISH if is positive, then you label them as HER2 positive tumors, and on ISH if the equivocal tumors are negative, then you call them again as HER2 negative tumors. Now coming to what exactly is this anti-HER2 targeted therapy, is we have certain drugs like Trastuzumab, Pertuzumab, or Trastuzumab M10sin. So these drugs are basically targeted against this HER2. So which are the patients who will be benefited by this therapy are those patients which on IHC are showing a 3+ expression, or if equivocal but on in situ hybridization they are showing a positive gene amplification. So that is HER2 positive tumors. These tumors are benefited more by this anti-HER2 targeted therapy, right? But the patients who are having IHC expression of 1+ or 0, they will not respond. So they were historically labeled as HER2 negative tumors. However, the recent studies, especially the Destiny Breast 04 trial, has found that even the tumors with low HER2 expression, that is IHC score of 1+ or a 2+ with in situ hybridization being negative for gene amplification, they also respond to a new drug, that is a Trastuzumab Deruxtecan, which is an antibody-drug conjugate. And because of this, now no more these tumors are considered as HER2 negative. They are considered as a separate biological group, that is low expressors, which can still be targeted by some therapy. One should note that HER2 low is not a separate ASCO cap category, but it is a clinically relevant for therapy selection. As more and more advancements are going, the ongoing trials like Destiny Breast 06 has also recognized another subtle group, that is HER2 ultralow. This is now defined as barely perceptible incomplete membrane staining in less than 10% of tumor cells. These cases were previously reported as IHC 0, as we have seen in our previous table as well, but now they may respond to antibody-drug conjugates because of the minimal HER2 expression, which will lead to the drug internalization, and hence they are again now not called as HER2 negative tumors but are labeled as HER2 ultralow. Now, why is there so much discussion around these HER2 tumors, and why we as pathologists must care? Is because these HER2 positive tumors are going to be very aggressive. They are usually higher grade tumors, and HER2 positive tumors usually show increased recurrence and risk of metastasis. Now, the patients who are positive for this HER2 expression, they usually respond well to this anti-HER2 therapy, and because of which there is a marked increased improved survival in such patients. So the shift from binary, that is a positive or a negative for HER2, to a quantitative HER2 expression spectrum means accurate IHC scoring is very much crucial and very much important for the therapy access. And mislabeling a 1+, that is a HER2 low tumor, as 0 mean that you are denying the patient of a life prolonging treatment. Along with all of this, it is very much important, very much crucial and mandatory that you also take into consideration certain pathological pitfalls whenever you are reporting this HER2 expression. So cold ischemia time should be known, and the time of fixation must be considered. Also, do not misinterpret cytoplasmic staining as a positive expression. Again, reassess the HER2 in recurrent or the metastatic sites as well, because they may be differing from the primary tumor. And again, decalcified bone metastasis should not be used for testing of HER2 expression. So to conclude, HER2 is no longer just a positive or negative, it's a continuum, and accurate distinction between the HER2 low and HER2 0 and ultra low now directly determines the eligibility for the targeted antibody-drug conjugate therapy. Now, a quick question for all of you. I would really appreciate if you can give the answer to this in the comment section below. So, apart from breast cancers, HER2 overexpression can be seen in which of the following cancers? A. Gastric cancer, B. Endometrial cancer, C. Lung cancer, D. All of the above. I will be posting the answer after a week in the comment section. Thank you so much for your patient listening. I really would appreciate if you can share this presentation with your fellow colleagues or students the main purpose behind this is to make everyone aware about the various nuances that are taking place in the field of oncopathology per se. I am also learning, you are also learning, so it would be very nice if you could also suggest me certain suggestions of yours, or we can discuss the queries or the other related topics that you want me to discuss in the comment section below. I will go ahead likewise. Thank you so much for your time. Have a great day.